record on this computer. So, okay, so good afternoon, everyone. So this is a lecture on endocrine system. So we will cover the content for the new system, the endocrine system. It will be two components. It will be like two lectures today and on Friday. That will be the second one. So the first half of the endocrine system will be done today, and then the other half on Friday. So let's start with the basic, because this is the only system I do cover EMP, given not just the complexity of the system, but also because it's based on understanding the hormones and its the function of these hormones and the source of the hormones, the glands that produce and secrete these hormones. So that's why that's one of the only system I do cover both EMP, the anatomy and physiology, and the alterations of the pathophysiological processes and diseases affected by the endocrine system. So the first slide here shows the different type of glands which compose or consist the endocrine system. And the master gland is called, what's the master gland that controls all the endocrine system, hormones and glands? On the top goes the, which gland?
The hypothalamus.
Hypothalamus. Yeah, the hypothalamus controls everything in terms of the endocrine system, glands and the target glands and the hormones produced by each and every one of these glands. So the hypothalamus, which is a neuroendocrine gland, and then we have the adrenal glands, thyroid glands, the pancreas, which is specific cells in the pancreas, which is the islets of Langerhans and the pancreas, which produce the insulin, and parathyroid glands, small, tiny glands in the back of the thyroid, and then the gonads, the testes and the ovaries. So the hormones, as we said, that begins with the control, kind of super control, and the master control will be from the master gland, which is the hypothalamus, which will secrete hormones to control the other glands. Like the most the gland that is going to produce most of these hormones is the pituitary gland. Pituitary gland is composed of two sections or two components, anterior lobe and then the posterior lobe. The anterior lobe, it's controlled or connected with the hypothalamus through the blood vessels. And then the posterior lobe is heavily connected with the nerves. So the list of the glands, these slides talk about the difference between protein hormone versus the steroid hormone. The protein hormone, which is water soluble, that's binds to receptors, and then the protein hormone will make, because the protein hormone is supposed to do some alterations or changes when it enters the cell. So it will activate the various cell processes as they enter the cell in the cytoplasm. However, the steroid hormones, they will enter the cell and then they supposed to do these changes once it enters the nucleus, not the cytoplasm, inside the nucleus. So they can stimulate the protein synthesis. So some differences between different types of hormones. This slide shows the mechanism of the changes and response of the fluctuations in the hormones. mechanism of hormone action would be what is called the low concentration of hormones would increase the number of receptors per cell, which is called upregulation. The high concentration of hormone decrease the number of the receptors, so which is called the downregulation, which is the feedback mechanism. And we'll cover the feedback mechanism and give you some examples of how the feedback mechanism would work. But this one is in reference to the number of receptors, either upregulation or downregulation. So the low concentration of the hormone will increase the number of the receptors on the cell. That is called upregulation. And when they're with a high concentration of the hormone, that will decrease the number of the receptors, and that is called downregulation. And I will go over the different type of mechanisms, which is the feedback mechanism, which govern the release of the hormones in the endocrine system. Negative versus positive feedback mechanism. So the endocrine system, it's different from the rest of the systems, is that look at the vascular system or cardiovascular system. It's connected, blood, the heart connected to blood vessels, capillaries, it's all connected. Continuous connection. But with the endocrine system, hypothalamus, and then we have T gland, pituitary gland, and then we have other glands like thyroid, pancreas, gonads, right? So they are not physically connected, because when each one of these glands will produce the hormone is going to be released into the bloodstream, and then it will target through the blood, it will target the tissue, or right? So which is the endocrine system. That's why we call the endocrine system is a ductless glands, or these glands are ductless glands. They are not connected with with each other or with the target tissue. So the hormones act only on cells that have receptors specific to that hormone. I believe that we started recording, right? Oh, okay.
Yes, it's recording.
Yeah, good. Okay, just make sure that we. All right. So the hormones, they act only on cells that have receptors specific to that hormone. Because again, the shape of that receptor determines which hormone can react with it. And that is called a lock and key model of biochemical reactions. Each receptor has a specific hormone, or each hormone has specific receptors going to activate, the physiological process and mechanism, right? And result in changes in the cell. Metabolism, absorption, and we'll go over some of the functions of these hormones and give examples of each. So first of all, let's just review the hormones that are secreted from different glands. Let's give you an overview of the different hormones produced by, different glands. Hypothalamus, it produce, for example, the CRH. TRH, like thyroid releasing hormone. And anterior pituitary gland and posterior pituitary gland. So we have two different lobes, like anterior and posterior. The anterior produces more hormones than the posterior one. So pituitary gland, just call it P gland. The anterior produces the TSH hormone, which is thyroid stimulating hormone to stimulate the thyroid to produce T3 and T4. ACTH hormone, adrenocorticotropic hormones, to stimulate the adrenal glands on the third, the kidneys, to produce hormones like cortisol, aldosterone, and then the anterior also gland, anterior P gland, produces the luteinizing hormone, FSH hormone for ovulation, to stimulate the ovaries to, right, for ovulation, prolactin hormone during lactation. And the positive feedback mechanism would be the baby when the sucking reflex produce large amounts of prolactin. So most of the mechanisms and the endocrine system is of a negative feedback mechanism, not positive. You'll find few of them, few positive, like the prolactin in response to the baby's sucking reflex, but most of the mechanisms are negative feedback. And I'll give you a few examples of the negative feedback mechanisms. The MSH was, melanocyte hormone, stimulating hormone, and then the GH is a growth hormone. So you can review all these hormones and see that the function of for every and each one of these hormones, there's each specific function, and that pertains to the EMP. It's just the time to review the functions for these hormones. Now, this slide shows the HPT, and I would always refer to the HPT, which is the hypothalamus, pituitary, and target organs, as the 3 levels of management, like higher level, intermediary, and lower level management. Is that the higher level would be the hypothalamus, and then giving orders to the P gland, and the P gland will give orders or hormones. The orders are given in the form of hormones. So the P gland produce hormones to stimulate other glands to produce also other hormones. So an example of that, the P gland or pituitary gland, for example, it will release the TSH hormone to stimulate the thyroid hormone to produce hormones called T3 and T4, thyroxine and triiodothyronin. And you have lots of examples like that. The posterior loop of the P gland produces only 2 hormones, oxytocin and ADH hormone, or what is called the vasopressin hormone. ADH or vasopressin is the same, and oxytocin, which is the hormone needed for the uterine contractions during labor. And that's another slide explaining the 3 levels of the HPT feedback mechanism. And I'll give you few examples of the feedback, which is negative feedback mechanism. The first one is the feedback mechanism between glucose and insulin. So the increased glucose level in the blood will stimulate the increased insulin production from the pancreas. So the blood glucose level will decline because the insulin assists the glucose molecules to enter the cell, the glucose to enter the cell for metabolism. Otherwise, in the absence of insulin or insufficient amount of insulin in the plasma, that will result in more glucose molecules to be present in the bloodstream, which is called hyperglycemia. And when we get to the diabetes type 1 and type 2, you'll find the difference between type 1 and type 2. When the insulin is type 1 is absent, completely absent, versus type 2 when it's insufficient. Another example of the feedback mechanism, which is the best example aside from the hyperglycemia and the insulin production by the pancreas, is the feedback mechanism, which is another negative feedback mechanism, which is the PTH hormone and calcium. The parathyroid hormone, so take a look at the thyroid gland. Which is parathyroid glands. Do we have a good picture of the parathyroid gland here? I mean, you see how the thyroid in the back, posteriorly, like posterior view, in the back of the thyroid, there are 4 small, tiny parathyroid glands. So the PTH, so these 4 small glands in the back of the thyroid, they are responsible for producing the PTH hormone, parathyroid hormone. So the PTH hormone, major function for the PTH hormone is to control the calcium. Anytime the calcium level drops, PTH hormone will rise, because these glands, they have like sensors. They will sense the drop or decline of calcium level. Parathyroid, the P gland will start producing. I'm sorry. The parathyroid gland will increase the secretion of the PTH hormone in an attempt to the homeostasis. It's always these glands work, produce hormones or decrease production of the hormone to reach the homeostasis. So when the calcium level, drops below the significant numbers, then the PTH hormone will rise. So these hormone will increase. So the PTH hormone will increase in production by the parathyroid glands in attempt to stabilize the calcium or bring calcium back to normal levels in the plasma by doing 3 mechanisms. So this is now the pathophysiology, how these hormones, which is the PTH hormone, will bring, or correct the hypocalcemia. So one of the questions would be, what is the factors that will result in the increased production of PTH hormone? It is the hypocalcemia. So anytime the calcium level drops in the blood, then the PTH hormone will rise. So the PTH hormone, it will bring back that calcium level, the hypocalcemia, back to normal by doing one of the 3 things, or all the 3 mechanisms. The first attempt to increase the calcium level would be by increasing the calcium so it's 3 target organs. It will have a function on the bones, on the GI tract, and intestine and bones and kidneys. GI, bone, kidney. On the GI tract, it will increase the calcium absorption. On the bones, it will start what is called calcium resorption, which means pulling the calcium from the bone into the bloodstream. The third mechanism is to increase the calcium by working on the kidneys by doing one of 2 things. Either it will increase calcium reabsorption, bring calcium back to the bloodstream, or decrease the calcium excretion, so you can retain the calcium. So by doing all the 3 mechanisms, the PTH hormone can control or can fix the hypocalcemia and bring that low calcium blood level back to normal. Unless it's very significant levels that that when the PTH, the parathyroid glands, are able to fix it or reach homeostasis, then we have to intervene medically and give the patient supplement or give patient medication. But that's the natural, normal homeostasis in terms of feedback mechanism. Again, this is ADH hormone and oxytocin. That's a function of some hormones, like the posterior lobe of the P gland produces we said ADH hormone and the oxytocin. ADH hormone responsible for, what is the function of the ADH hormone? when you see anti-diuretic hormone, which means from just applying the name, anti-diuretic hormone.
You retain water?
Right. It's anti-diuresis. Sometimes they're confusing when it comes to ADH hormone and the function and then the medications or the diagnoses that is associated with it, or pathophysiological changes or mechanisms with the ADH hormone. But just remember that the ADH hormone, just from the name of the hormone, it's the diuretic hormone, which is anti-diuresis. It will prevent the loss of the fluids, which means, in other words, that it will retain fluids. Anti-diuresis. So it will retain fluids. So the ADH hormones, more production of the ADH hormones. So always ADH hormone, vasopressin and oxytocin belong to who produce them? The posterior loop of the pituitary gland. So the increased production of the ADH hormone is going to retain more fluids. Patients will retain lots of fluids because that's anti-diuretic hormone. Patients who are unable to produce, posterior P gland, produce insufficient amount, but a small scan amount or insufficient amount of ADH hormone, then they won't be able to retain it, right? So they will lose the fluids, which is in this case will be called diabetes insipidus. And we'll cover that later on. But just now to try to understand the functions of these hormones, very important because this is I would say this is the key elements of understanding, better, to better understand this chapter is to review the hormones and the functions of these hormones. These are some of the changes or alterations due to aging and the lab tests. Well, we have two different types of testing, which to diagnose patients with endocrine diseases or disorders. One of them is called stimulation test, and the other one is suppression test. So stimulation test is that when you stimulate the gland to produce the hormone, and we have different examples of this. It's just to understand the concept behind the stimulation testing and the suppression testing, is that when you attempt to stimulate the hormone, the gland is to administer the patient like steroid, right? To stimulate the adrenal gland to produce, to to test the response, or to assess the the adrenal gland. So the failure of so this one applies when you see stimulation test, that applies to all different testing of stimulation testing. It's the failure of the hormone level to rise with stimulation that should indicate hypofunction. So you are administering that hormone and the patient's hormone did not go up, or blood level didn't rise with that stimulation. So that will indicate the hypofunctioning, because the endocrine system, the best way to understand all these disorders of the endocrine system and that affects the endocrine system is by hypo and hyperfunctioning. Patients with diabetes, hypoglycemic or hyperglycemic. Patients with ADH, with the H hormone problems, either there's an insufficient or excessive amount of ADH hormone. Too much of ADH hormone, that's IADH, syndrome of inappropriate ADH hormone, versus patients with insufficient ADH hormone, that's diabetes insipidus. Thyroid hormone, too much of T3 and T4, hyperthyroid. Insufficient T3 and T4, hypothyroidism. Same thing for the PTH hormone, too much, hyperparathyroidism. PTH hormone, insufficient, hypoparathyroidism. So most of these endocrine disorders can be explained in a dichotomy kind of format, hypo versus hyper. Too much of steroid, Cushing syndrome. Insufficient of steroids or cortisol, Addison's disease. And they are dichotomous. So everything is heightened, and like Cushing syndrome, very minimal decrease to the lowest level in Addison's disease. So if you master one side, it's much easier to predict the other side, because that's dichotomous kind of disorders when it comes to like hypo versus hyper. So the stimulating testing, the failure of the hormone level to rise with the stimulation, because you administer the medication or hormone to stimulate the gland. So the failure of the hormone to rise in the blood with that stimulation testing, that indicates the hypofunctioning of the gland. It aids in diagnosing. It will assist in us as we diagnose the patient with different types of the endocrine disorders. And the suppression testing would be the opposite. Failure of the suppression hormone production during testing, that would indicate hyperfunctioning. Failure of the suppression of hormone production, because you're trying to suppress the hormone, the gland, so that the gland would produce more, because when the gland sense there is the decline or decreased amount of hormone, supposed to react by secreting more hormone. For example, if the thyroid's supposed to produce T3 and T4, who stimulate the thyroid gland? Which gland? So we said 3 levels. Right. 3 levels. Hypothalamus, right? Pituitary gland and then thyroid gland. So the thyroid gland unable to produce sufficient amount of T3 and T4 its own, that's the gland job is to produce T3 and T4. So if the thyroid gland unable to produce sufficient amount of T3 and T4 thyroid hormones, then the message will be sensed by the P gland, because the P gland stimulate the thyroid gland by producing which hormone? How would the thyroid be stimulated to produce the T3 and T4? Supposed to get orders from the P gland. Which hormone would be coming from the P gland, pituitary gland, to stimulate the thyroid to produce the T3 and T4?
Thyroid stimulating hormone?
Right, TSH hormone. Thyroid stimulating hormone coming from the anterior lobe of the pituitary gland to stimulate thyroid gland. I'm giving you one example because if you master one example, you can apply it to all glands, all other glands. So try to master one. Thyroid, that's the easy one, and that's the most prevalent disease, hyperthyroid versus hypothyroid. You see in the hospital too. So pituitary gland produce thyroid stimulating hormone, TSH hormone, to stimulate the thyroid gland to produce the thyroid hormones T3 and T4. So if the thyroid gland unable to produce sufficient amount of T3 and T4, that will be sensed by the anterior lobe of the pituitary gland. This will be sensed to say that we need more of this T3 and T4 be produced. It will stimulate the thyroid by producing too much of that TSH hormone. So you will see more stimulation by more production of TSH hormone to assure that the thyroid is going to produce more, if the thyroid can do it, right? So that is just briefly trying to, it is one of the complex concepts and lab testing, suppression, and the stimulation testing. I'm not going to focus much on it. It's just to give you at least brief definition of what is the stimulation test and the suppression test. Some of the testing would be like urine test analysis. In this case would be the 24 urine hour collection. For example, patients with a adrenal gland tumors or problems, Cushing syndrome, Addison's disease, or pheochromocytoma. We know that when the hormones are produced, aside from the cortisol, we have also the aldosterone, and then there is also some epinephrine, which is the catecholamines produced too, because we have adrenal cortex versus adrenal medulla. Now, the metabolites of this cortisol would be present in the metabolism of the cortisol would be present in the urine. So the more metabolites of the cortisol metabolized in the urine, that's an evidence that the patient is producing too much of these catecholamines. Catecholamines means epi and norepinephrine, which would reflect that the adrenal glands are, diseased or, maybe dysfunctional. So we will collect the urine over 24 hours and this into the lab, and then we request a specific testing looking for these metabolites in the urine. So let's start with the pituitary gland in terms of the hypofunction versus the hyperfunctioning. Again, all these glands are going to be discussed and covered in that kind of, dichotomy of hypo versus hyperfunctioning. And all of these endocrine, dysfunctions or disorders that should be explained in that way, with that format of hypo versus hyperfunctioning. So the hormones of the pituitary gland, we said we have an anterior lobe and posterior lobe. A posterior lobe produces the ADH hormone and oxytocin, and the anterior lobe produces more hormones like growth hormone, prolactin, TSH hormone, ACTH hormone, FSH hormone, LH hormone, MSH hormone. All these hormones are produced from the anterior lobe of the pituitary gland. So when the anterior lobe of the so that's now we are this look at the anterior lobe, given that it produces all these hormones, growth hormone, prolactin, ACTH hormone. The hypopituitarism versus the hyperpituitarism. Hypopituitarism means that the anterior lobe will produce less of these hormones, less of the growth hormone, less of the prolactin hormone, less of the LH hormone, and there is no specific one clinical picture of patients with when the anterior lobe is affected. Some would have only one hormone affected, others more than one hormone. So, but I just need to know that the hypopituitarism will include or involve these hormones, decreased production of these one or more of these hormones, and the hyperpituitarism that will result in increased production of one or more of the aforementioned hormones. However, the posterior pituitary gland, which is we said it's in we call it a neurohypophyses, which is because it's connected with the hypothalamus through heavily with the neurons and nerve tracts. It controls so it has a specific function focused on fluid electrolyte balance and uterine contractions. Uterine contractions, that's for the oxytocin, and then the ADH hormone, vasopressin, to control fluid and electrolytes. So patients whose the posterior loop of the P gland will produce lots of the ADH hormone, too much of ADH hormone produced, that's called SIADH, which is syndrome of inappropriate antidiuretic hormone. But when it's a very small amount and sufficient produced is of the ADH, then that is EDI, which is diabetes insipidus. That is called diabetes insipidus. And diabetes insipidus is there are few features of the DI that is very similar to patients with diabetes mellitus, like polyuria and polydipsia. That will be like two common ones between diabetes insipidus and diabetes mellitus, because that's of the diuresis and loss of the fluids, polyuria and polydipsia, which is excessive thirst. Polydipsia, excessive thirst. Polyuria, too much urination. So this is more explanation about the hypo and hyperpituitarism. Hypopituitarism, which is decrease in the secretion of vital hormones. We have some etiology. Anytime you see that etiology is idiopathic, means there is no identifiable or cause for that, so cause is unknown. Postpartum hemorrhage, there is a syndrome associated with that, what's called Sheehan's syndrome. You don't have to know this, but at least just to know that postpartum syndrome, hemorrhage, that could result in hypopituitarism because of the decrease from the hemorrhage that results in decreased perfusion to the pituitary gland, and then that results in the hypopituitarism. That's why that etiology is valid. Hyperpituitarism, which is when the overexcretion of the hormones from the pituitary gland, and most of the time is that you will find that the oversecretion and hyperpituitarism, that's due to the tumors or hyperplasia of the gland, of the P gland. Benign adenoma, the most common cause, or sometimes it's hypothalamic problem within the hypothalamus, and that will affect the P gland. The growth hormone, for example. So again, I said there is no one clinical picture of all patients with hypo or hyper, especially with hyper. It depends on which hormone is affected. If the growth hormone is oversecreted, for example, here, then the patient will develop the gigantism or acromegaly. Depends on the when that hypersecretion had started, like before puberty or after.
Professor, I have a question.
Yes.
So hyperpituitarism or hypo, it is not one. It's not specific to a gland. It could be any one of the glands.
No, it is the pituitary gland, but it can be the P gland itself, the pituitary gland, or it's coming from also the thyroid, the hypothalamus as well.
Okay.
Yeah, because remember that it said hypothalamic problems, but most of the time it is due to, it's the most common one, it's always benign adenoma, tumor affecting the gland itself. That's most of the time. Unless it's, coming from the hypothalamus, that's why it's going to affect the P gland. But most of the time it's the benign adenoma or hyperplasia affecting the gland, the P gland itself. So when there's too much of the growth hormone produced, then the patient will exhibit what is called gigantism or the acromegaly. When another example is when there is too much of prolactin hormone, which is responsible for the lactation during the the lactation period, that could result in amenorrhea, infertility, or galactorrhea. So we have different examples of when the hyperpituitarism will increase the secretion of one or more hormones, would result in specific disorders: gigantism, acromegaly, galactorrhea, hyperglycemia. For example, even growth hormone, when it's increased in terms of production, it will produce, we said, gigantism or acromegaly, but also it will result in hyperglycemia as well, because the growth hormone, it's an insulin antagonist. It works opposite to the insulin function. So that will result in more growth hormone, which means hyperglycemia would result. Hyperglycemia, blood glucose level will rise. ACTH hormone, let's say that patients with adenoma or hyperplasia of the P gland, anterior lobe, resulted in excessive secretions of ACTH hormone. And we know that the P gland produces this ACTH hormone, adenocorticotropic hormone, to stimulate the adrenal glands on the tail of the kidneys to produce, hormones like cortisol and aldosterone and catecholamines. So excessive production of this ACTH hormone would result in the Cushing syndrome. Stimulation test, don't worry about this because again, this this is one of the difficult concepts in endocrine system, so I don't want to really focus on the stimulation suppression test for now. So treatment would be to for patients, we'll cover this in Adult Health 3, senior fall semester. We'll go over the modalities, surgical treatment modalities for adenoma of which affects the P gland. So they do something called transsphenoidal hypophysectomy. You don't have to know this, but this is like a surgical procedure to remove the adenoma or the gland when it's affected by a tumor. These are examples of the acromegaly and the gigantism in response to the excessive production of growth hormones. That was the anterior lobe of the P gland. Now the posterior lobe of the P gland, we have either excessive production of the oxytocin. We don't focus on oxytocin because oxytocin hormone is produced during the when you see the production of the oxytocin mostly during the given the function of oxytocin when it's produced in large amounts.
You're saying oxytocin?
Oxytocin, yes.
So like when breastfeeding, right?
Most would be during labor. Yes, labor. So why I'm saying oxytocin, because there are only two hormones produced from the posterior lobe of the P gland: oxytocin and ADH hormone. ADH, which is vasopressin. Oxytocin, we said it's a hormone to assist in the contraction of the uterus, uterine contractions during the labor that's needed. So that's the oxytocin function. And additional functions too, but that's the very limited function, and it has very limited use, right? So that's during the labor. What about the ADH hormone? It controls fluid and electrolytes. Any excessive production or decreased production of this ADH hormone, which is called vasopressin, would result in detrimental manifestations and signs and symptoms. So first of all, let's start with when the P gland the posterior gland produces a small amount, insufficient amount of ADH hormone, which is called ADH deficiency. That will result in something called diabetes insipidus. So the DI results from the ADH deficiency. So we know the function of the vasopressin or ADH hormone to control fluids and electrolytes. So the diabetes insipidus would result from the insufficient amount of production of the ADH hormone by the P gland, the posterior lobe of the P gland. And that can result either from, classification of the diabetes insipidus could be that the kidney tubules, so nothing wrong with the hormone. Hormone is present. It's, there's ADH hormone, sufficient amount, but the kidney tubules, kidneys do not respond to the actions of the ADH hormone. And that's genetic, nephrogenic, genetic in nature. The second one will be the primary central or neurogenic. There are different textbooks that refer to that as the genetic, or some call it central. Other textbook call it primary. So it depends on the textbook you are using or being used. And then the second one, so the primary secondary, that is, the primary central or neurogenic, that is, if there would result if there is a defect in the hypothalamus or the pituitary gland. Secondary would be like if there's a tumor, if the patient survived a head trauma or infections to the brain, or when the patient who had survived this surgery, the transsphenoidal hypophyseectomy, or sometimes it's due metastasis, cancer metastasized to the brain, and that affects the P gland. The last one is the drug induced. You will be able to associate with the drug induced diabetes insipidus when you in the fall, when you take the mental course, and then you go over the medications. One of the meds is the lithium carbonate, and that's one of the drugs, psychotic or psych medications called lithium carbonate that could result in the deficiency of ADH hormone production, which is called diabetes insipidus. So again, if you master the diabetes insipidus, you easily can predict the SIADH mechanism, the signs and symptoms, the urine and plasma, which one is concentrated, which is diluted. So let's just for now focus on the diabetes insipidus. Given that the hormone, ADH hormone, is insufficient, deficiency, then the patient cannot hold or retain the fluids. So the patient will have less of fluid loss in the urine. So that's the diuresis, polyuria. From fluid loss will result in polydipsia, which is excessive thirst. Patient over 24 hours can lose over like more than 4 liters of urine daily. And that would result in generalized weakness and fatigue, dehydration. So the urine versus the chemistry or the plasma, urine versus plasma, urine will be diluted and then the plasma will be concentrated. So everything in the urine will be diluted. So which means everything is going to be decreased. Urine pH, sodium, urine potassium, even the osmolarity, which is the concentration of the urine, will be decreased. Specific gravity less than 1.005. Everything is decreased, and then the chemistry will be, and the blood will be concentrated. Everything is going to be elevated from the loss of the fluids. The opposite, if you master this clinical picture of a patient with a DI, diabetes insipidus, you can predict easily patient with SIADH. We'll get, when in adult health 3, we'll get to the how would you treat patients with DI, for like example, is it mild diabetes insipidus versus severe? With the severe cases of diabetes insipidus, you'll give the deficiency of the ADH hormone, which means we have to give the patient vasopressin, synthetic vasopressin. We'll give them the demopressin, for example. Itresin can be given as a supplement or as as to replace the insufficient amount of vasopressin produced or ADH hormone produced by the P gland. The SIADH, which is syndrome of inappropriate ADH antidiuretic hormone. Even though, so we have, the patient will have the gland, the P gland, the posterior lobe of the P gland produces too much of the ADH hormone, so the patient is going to retain fluids. And these are some of the causes of the SIADH hormone disease. So the feedback mechanism completely shut down or ineffective, do not function properly. So the water would be retained, and the patient do not usually patient will have a dilutional hyponatremia. even though they have sodium retained, but given the large amount, the massive amount of fluid retained, the patient will have that amount of sodium will be diluted with, within the fluid retention. So that results in dilutional hyponatremia. And that's would explain also why the patients retain fluids and they usually do not develop any edema or swelling. So if you want to get to the bottom of the mechanism why the patient with ADH, with the SIADH hormone, they retain lots of fluids. They do not develop edema or extremity, like in patients with heart failure, they will have edema, lower extremities, edema and swelling of the lower extremities. But in this, this scenario with the SIDH, they do not develop edema, and that's because of the mechanism is called dilutional hyponatremia, would prevent them from developing the edema. So they will have a water retention, the weight gain, edema. We said it's not present in ADH from SIADH because of that dilutional hyponatremia. Patient will have signs and symptoms of hyponatremia, fluid volume excess. That's going to affect the lungs and result in crackles in the lungs. And the manifestations would be, as you assess the patient, that is exactly opposite to patients with diabetes insipidus. Urine is going to be concentrated, opposite to the DI. Urine or chemistry will be diluted, opposite to the DI. Okay, so any questions so far? Questions?
Do you mind, excuse me, would you mind repeating why edema is not
Because I would explain it as a dilutional hyponatremia. The amount of sodium will be distributed over a large and massive amount of fluids retained in the body. That's the explanation why there is no edema.
well, thank you.
You're welcome. Now for the next gland, which will be the thyroid gland. Patients with thyroid, first of all, the thyroid gland produces the thyroid hormones, T3 and T4. And these thyroid hormones regulate the body metabolism, responsible for the energy production. They also regulate fluid and electrolyte balance, in addition to control the body use of fat, protein, and carbohydrates. So patients with goiter doesn't mean that it's always connected to the hypo. Sometimes patients with hypo would have a goiter, which is the enlargement of the thyroid gland. And as well as patients with hyperthyroid also, they will develop the goiter as well. So the enlargement, hypertrophy, and enlargement of the thyroid gland is called goiter. And that could result from excessive TSH stimulation or growth stimulation immunoglobulins, goitrogens, or which is going to be medications or food or that contain thyroid inhibiting substances. So it affects only individuals who live in iodine deficient areas. People who live like in a shoreline, like close to the sea or ocean, they tend to have more of iodine in the atmosphere, so then get this kind of problem of the goiters or goiter kind of related thyroid problem, because they have that iodine in the atmosphere. So the supplements, that's why you always, when you get the salt, make sure that it's iodized salt, so we can prevent. So that's what is called the goitrogens. Now the Graves' disease, which is the when the T3 and T4 is extremely high, that is called a Graves' disease. It's one form of the hyperthyroidism. Hyperthyroid disorders. 75% of patients with hyperthyroid disorders is called Graves of that type, Graves' disease, because there are different, types of hyperthyroid, but Graves' disease is the most common one. There are also goitrogens like medications, drugs. If iodine taken in large doses, that could be also would result in goitrogens and result in goiter, like enlargement of the thyroid gland. Lithium, another one. A cardiac drug called amiodarone. Cardiac medication called amiodarone. It's antidysrhythmic medication. It has that one of the side effects is, it's a goitrogen and could result in enlargement of the thyroid gland. This slide shows or figure, kind of, differentiate between the hypo versus the hyperthyroidism. Anyone ever took care of a patient with hyper or hypothyroid? Can maybe relate to the sinus symptoms? Did you ever have any experience of hypo or hyperthyroid patients? Anyone?
Hypothyroid patients have they have weight gain. Both can have a goiter. Hyperthyroid are going to have weight loss. Their metabolism is going to be too high. They're
Yes.
going to have they're going to not be able to deal with cold. They're not going to want to eat. They're going to be kind of always feeling like sort of like too much energy, but like nervous energy. And
Right.
then hypothyroidism, they're going to not really be able to do much. They're going to be like
Tired, lethargic.
lethargic.
Yeah.
That's the word.
Yeah. Yeah. Good. Excellent. Yeah. That's again, this is another form of dichotomy, like hypo versus thyroid. I mean, hypo versus hyper. So hypothyroid patients will be like, generalized weakness, lethargic, like, sleepy most of the time, especially like at day hours. The patients with hyperthyroids, you cannot, there's no way you can find them like sitting like, still like in a chair or sitting like, or even in bed or, like in having like a nap or during the day, insomnia during the nighttime. They're hyperactive all the time. So all these behaviors go back to the metabolism. Too much of thyroid hormones or insufficient amount of thyroid hormones. And the function of the hormones, will provide an explanation why a patient with hypothyroid will be, experience the general weakness and fatigue and sleepy. And then the patient with hyperthyroid, because they have too much of T3 and T4, so that will make the metabolism, hyper metabolism, result in always asking for food. They can like have a meal like, in 10 minutes, and then will ask you for another meal. But at the same time, they don't gain weight, they lose weight. On the other side, hypothyroid, they don't eat much, but they lose weight, they gain weight. So it's all these manifestations of hypo versus hyper, it goes back to the function of the T3 and T4. So that's not a good slide, I think, to refer to, to differentiate between hypo versus hyperthyroid. The homeostasis of the thyroid hormone, healthy, no hyper, no hypo, that is called euthyroid. That's the normal, within range, hormones, behavioral, everything is within, like, healthy thyroid gland. That's euthyroid. Then on the continuum, on both sides, you'll have hypothyroidism, and then the emergency would be, the severe scenario would be myxedema, coma. On the other side, patient who's hyperthyroid, they can run into what is called the thyroid storm, thyrotoxicosis, another name for it, or thyroid storm. So here, thyroid storm, thyrotoxicoses, or hyperthyroidism. But just these two names, thyroid storm or thyrotoxicoses, that's interchangeably can be used. The thyroid hyperthyroidism, sorry. So I'm just going to highlight the most important, and you can read the rest of the slide in terms of like the prevalence and the percentage of differences in terms of gender and all of that. So the other causes. So we said the Graves' disease, that's the most common form of the hyperthyroidism. It's called Graves' disease, or what is called toxic diffuse goiter. The other causes, you can add which is exogenous iodine excess or thyroid releasing hormone from the hypothalamus. That is called exogenous hyperthyroidism. Patients, because they are eating or taking too much of iodine, resulted in iodine excess, that would lead to hyperthyroidism. So that's called, we call this exogenous hyperthyroidism. Thyroid tumors, thyroid cancer, the thyrotoxicosis, which is the thyroid storm, that is the physiologic effect of the hypermetabolism, result from the increased production of T3 and T4 thyroid hormones. So hyperthyroidism and thyrotoxicoses, they go together, they can occur together as Graves' disease. So Graves' disease will include both hyperthyroidism and thyrotoxicoses as a physiologic change. Graves' disease, it's an autoimmune antibodies that will mimic the TSH hormone. These antibodies, it's an autoimmune disease, so the antibodies present in the bloodstream is going to mimic the TSH hormone, and they are going to stimulate the cells of the thyroid to produce T3 and T4. These antibodies will behave like as if they are TSH hormone, and then it will result in more production of T3 and T4. What would precipitate the Graves' disease, the factors that would precipitate the disease, could be insufficient iodine supply, infections, mostly affecting the thyroid gland, and sometimes just these stressful life events, but interacts usually with the genetic factors. Stress, genetics together can result also in hyperthyroid. So the summarizing is that the antibodies will attack the TSH receptors or receptor sites in the thyroid tissue, which are being stimulated to release thyroid hormones. Antibodies, autoimmune disease, antibodies, TSH receptors, antibodies mimicking the TSH hormone, production of large amount of T3 and T4. Toxic nodular goiters. If the nodules are associated with hyperthyroidism, we call them toxic. If there are nodules in the thyroid gland, and then plus the hyperthyroidism, we call them toxic. And usually they are more than 3 centimeters in size in terms of the nodules, and when they are toxic nodular goiters. The patients will have tachycardia, palpitations, and that is explained because of the increased number of beta adrenergic receptors associated with that mechanism. There will be protein breakdown, which is degeneration, faster than the synthesis of the protein. So that the breakdown of protein will be faster than the buildup of that or synthesis of the protein. We call that negative nitrogen balance. Negative nitrogen balance. That's when you have a faster rate of protein degeneration, breakdown of protein faster than the buildup, the synthesis of the protein. That's called negative nitrogen balance, and that will be evident in patients with hyperthyroidism. In addition to the goiters, bruit, and which is bruit usually when you do the auscultation, ausculting in the thyroid for the stethoscope or the bell on the thyroid, you'll hear that bruit sound, which is a reflection of the increased blood supply. There's always increased blood supply, turbulence result in bruit, and then the ophthalmology or ophthalmopathy or exophthalmos. That is the abnormal eye appearance or function in patients with hyperthyroidism. And that's ophthalmopathy, or you can call it exophthalmos. These are the changes in the eye globe or the ophthalmic globe and the collection of fluids in the back of the eye. So the exophthalmos, because of the impaired drainage from the orbit, the globe, the ophthalmic globe, that will increase the fat and edema and the behind the orbital, the eye, which is the retroorbital tissue. Fluid and protein accumulates that results in the exophthalmos, like the bulging of the eyeball due to that collection of drainage, fluid, and fat behind the eye. So that's kind of, startled look or staring gaze. That's kind of, from the bulging or that exophthalmos. The consequences of this exophthalmos and the bulging and the protrusion of the eye, of the eye, that could result in a corneal ulceration, or sometimes eventual could result in the loss of vision. And it's usually seen in about 20 to 40% of patients with Graves' disease, the exophthalmos. Cardiovascular, it's a multi-system disease. When it comes to hyperthyroidism, it's a multi-system disease. Cardiovascular, increased cardiac output, but eventually the heart will fail from the hypermetabolism, will result in heart failure, dysrhythmias, palpitations, tachycardia. That's all from the increased beta adrenergic receptors and increased stimulation. Atrial fibrillation would result. Cardiac hypertrophy as well. GI symptoms, increased appetite, thirst, patient is, not asking for food all the time, right? And from the hypermetabolism, patient will lose weight from the accelerated, from the fast metabolism. Could also lead to hepatosplenomegaly. The skin changes and pigmentous changes, in addition to what I have listed as a warm, smooth, and moist skin, it will be dry skin in patients with hypo. So most of these symptoms, if you flip them, like to the other side, will become hypothyroidism. So patients with hypothyroidism will, will have the dry skin. Here we will have hair loss as well, clubbing of the fingers, which is called the thyroid acrobacy, which is the clubbing of the fingers, digital clubbing and swelling of the fingers. In addition to, sometimes I see a pigmentation. Hyperpigmentation also could result, which is like vitiligo. which is hyperpigmentation, due to the melanocyte destruction. Musculoskeletal, in patients with hyperthyroid, they will have the fatigue and exercise intolerance because they are active all the time. They are pacing the hallways, they are walking, it's hard to find them, sitting or even having a nap during the day. Insomnia during the, nighttime. Dependent edema, osteoporosis, and muscle wasting as well. The nervous system, they have a short attention span, inability to concentrate, delirium, mood swings, nervousness, irritability. So they are irritable most of the time. The reproductive system also some changes like the menstrual irregularities or changes. In addition to other manifestations, the patient will be intolerant to heat. It's hard for them to be covered with even a light sheet, day or night. And they have a glucose tolerance decrease or declined or decreased glucose tolerance, which means that they will be hyperglycemic. Hyperglycemic, elevation of glucose level. Complications from hyperthyroidism will be thyroid crises. So even there is immortality, or death. It's rare when treatment is initiated, but there is about 25% of mortality rate associated with the thyrotoxicosis or thyroid crises or thyroid storm. So thyroid storm, thyrotoxicosis, or thyroid crises or thyrotoxic crisis, 3 names can be interchangeably used. Manifestations, and next is the diagnosis. You will look at the TSH hormone. You'll find it is declined. There is an increase of free T4. In addition to that, T3 also will be elevated as well. You can use the thyroid scan like radioactive iodine uptake. Normally, the thyroid, this is like a radioactive material, radioactive iodine, and normally the thyroid gland healthy will uptake about 5 to 35% of the given dose. As you measure it in 24 hours in the blood, you will find that the thyroid has taken about 5 to 35% of that iodine. But in Graves' disease, so it can, you don't have to know about these specifics, but just normally the thyroid is supposed to take about 5 to 35% of the given dose of the iodine, which is iodine uptake, as you measure it over 24 hours. So they can be used for diagnosis. That can be, use the thyroid scan with the radioactive iodine for diagnostic purposes. Hypothyroidism, which is exactly the opposite what we have discussed with the hyperthyroid. The manifestations of hypothyroidism are the result of decreased metabolism and low levels of thyroid hormones. So the hyperthyroid person will be intolerant to heat. This one will be intolerant to cold. Always feel, they feel the coldness, or they're always cold. Even summertime, you find them wearing jacket or kind of like heavy coat, or cover themselves even in the summertime, hot weather. Summer time. So intolerant to cold intolerance, and hypothyroidism. It can be the hypothyroid. You will find more cases of hypothyroid, given that the hypothyroidism most of it is due to aging process or due to aging. So we have, primary hypothyroidism would be most common, caused by thyroid disease or loss of thyroid gland. Surgical procedure with the hyperthyroidism, patient go, for the surgical excision of the thyroid gland, subtotal or total thyroidectomy. Eventually, patient will become hypothyroid. Secondary will be caused by a failure of the anterior loop, anterior P gland to stimulate the thyroid gland, or failure of the target gland to respond to the TSH hormone. Like pituitary tumor would be an example of that. Failure of the target tissue to respond to the TSH hormone. Tertiary, which is caused by a failure of the hypothalamus to produce thyroid stimulating, releasing hormone, TRH factor or hormone, to stimulate the P gland to produce the TSH hormone. It can be transient to what is called thyroiditis, or discontinuance of thyroid hormone therapy. Because sometimes patient will be on thyroid hormones, synthroid, levothyroxine, right? And they stop taking the thyroid. That could be the tertiary type. So the hypothyroidism can be, the pathophysiology is the atrophy, would be the end result of the Hashimoto's thyroiditis, and even Graves' disease. The atrophy is the end result of Hashimoto's thyroiditis and Graves' disease, both of them. So Graves starts at hypothyroid, and eventually, when the tissue is destroyed, that will result in hypothyroidism. So again, the goitrogens are the substances that suppress the function of the thyroid gland by interfering with the iodine uptake, which will eventually can cause the enlargement of the thyroid, which is the goiter.
Professor,
Yes.
can you please make a difference for me between the goiter and thyroiditis?
Thyroiditis, it's goiter is
goiter.
enlargement. Goiter is the enlargement of the thyroid gland. And it can occur with hypo or hyper. Hashimoto's thyroiditis, for example, it's an autoimmune disease, and thyroid tissue is replaced by the lymphocytes and fibrous tissue.
Okay.
And that's the most common cause of the goiterous hypothyroidism, like hypothyroidism with the goiter, which is with the enlargement of the thyroid gland. The Hashimoto's thyroiditis is the most common one. It's an autoimmune disease with in which the thyroid tissue is replaced by lymphocytes and fibrous tissue. That's most common cause of goiterous, which is enlargement of the gland, goiterous hypothyroidism. So eventually, both Hashimoto's and Graves' disease, they end up with the atrophy of the gland. That's why they eventually, develop the hypothyroid. It can, it affects people at different ages, and that's why we have 3 different types of hypothyroidism: cretinism, juvenile versus adult. Clinical manifestations will be exactly the opposite, pretty much the opposite to what we have seen in patients with hyperthyroidism. Hypo, everything is very slow, everything is, decreased due to the decline in metabolism. Even patient doesn't have an appetite, but they still are gaining weight because of the decreased metabolism. Constipated, compared to patient with hyperthyroid, they will have a excessive or like frequent bowel movement, which is diarrhea, for example. The skin, dry, thick, elastic, cold skin. The puffiness of the face from the lipopolysaccharides collected in the under the skin. Musculoskeletal, they will have fatigue, weakness, muscle ache and pain, which is muscular ache and pain. In addition to the being fatigue, general weakness and fatigue, lethargic. So they will have cold intolerance. We do not recommend the external warming procedures or measures. The external warming measures are contraindicated because they can produce vasodilatation and vascular collapse. So the external warming measures, they are contraindicated in those patients because it can produce vasodilatation and vascular collapse. So this patient with hypothyroid, they develop the emergency or the extreme elevation of hormones would result in thyrotoxicoses, thyroid storm, or thyrotoxic crises. Here, the significant decline in T3 and T4 that would result in myxedema coma, accumulation of the hydrophilic mucopolysaccharides in the dermis and the tissues, and cause the puffiness of the face. And myxedema coma would be the most dangerous and life-threatening on the continuum with the hypothyroid. Myxedema coma, and that can be precipitated by cold, infections, some medications, traumatic events like trauma, infection, cold weather or cold temperatures, certain medications. It can precipitate this myxedema coma in patients with hypothyroid. The hyperparathyroidism, which is the parathyroid, 4 tiny small glands in the back of the thyroid. That's the exact anatomic location or site for these 4 parathyroid glands. And we said that one of the major functions of the PTH hormone, which is the hormone produced by the parathyroid gland, is to control the calcium level. And once we control the calcium, eventually we can control the phosphorus as well. Because calcium and phosphorus, and phosphate or phosphorus, they inversely related. I did explain the function, how the hypocalcemia would result in the increased PTH hormone, and then that will 3 mechanisms on the bone, kidney, right, and the GI tract. Then that will bring the calcium back to normal, bring it back to homeostasis. So the effect on the bone, the long-term calcium excess, it can release the calcium is to be deposited in the soft tissues. So that's from the hyperparathyroidism. Too much of the PTH hormone is produced. Eventually, that will result in a lot of calcium deposited in the soft tissues from the hypercalcemia. And that also can, in certain patients, will result in more kidney stones to develop. And I did explain this mechanism already in the previous slides. Hyperparathyroidism, the pathophysiology for hyperparathyroidism is that the PTH hormone indirectly increases the GI absorption of calcium, which will further contribute to the high calcium levels in the blood. So it will rise and increase the calcium levels in the blood and cause and result in hypercalcemia. 3 different levels or 3 different forms can be primary, secondary, secondary or tertiary. Primary, most common cause is benign tumor or adenoma to the parathyroid gland, 1 or more of the 4 glands, or in patients who had previously underwent or had the head neck radiation, they will be at high risk to develop the primary type head and neck radiation to treat the the cancer. Secondary hyperparathyroid would be diagnosis would include like vitamin D deficiencies, malabsorption, so the increased PTH hormone levels cannot achieve the normal calcium because of insufficient levels of activated vitamin D. That's in patients with chronic renal failure. Because the kidney is responsible for the activation of vitamin D. And we know that the calcium won't be absorbed in the absence of vitamin D. So in patients with chronic renal failure, they will have insufficient levels of activated vitamin D. Given the kidney is responsible for responsible for the activation of vitamin D. So with that insufficient level of activated vitamin D, that in response to that, there will be an increased PTH level, parathyroid hormone level, in response to that, the negative feedback mechanism. And that will result in more calcium production. Tertiary, which is autonomous secretion of PTH hormone, even with normal calcium levels, which means that there is a loss of the feedback mechanism, which controls the calcium level. And this type of tertiary hyperparathyroidism, it's seen in patients who had a kidney transplant after a long period of dialysis for, to treat the end-stage renal disease. Patient who had, that kidney transplant, they have shown to, to exhibit or to have this type of tertiary type of the hyperparathyroid. Hyperparathyroid can be iatrogenic. So hypoparathyroid, which is decreased production of PTH hormone, so that will result in hypocalcemia. So who would be at risk to develop the iatrogenic one? When you say iatrogenic, which is caused by iatrogen, in Greek means medical, doctor. So iatrogenic hypoparathyroidism, which is kind of result from like an intervention by a professional, a physician, practitioner, nurse, or so that's which means it's an intervention related. So iatrogenic hypoparathyroidism, that's the most common cause or form of the hypoparathyroidism. But who can give me an example of that? Patients who would develop the hypoparathyroidism of this type, iatrogenic. One of the treatments for the thyroid gland hyperthyroidism, one of the surgical procedures will be a subtotal or total thyroidectomy. And during that surgery, the first step is to preserve and protect the parathyroid gland They don't want to remove them with the thyroid, so they will preserve them. Sometimes accidentally, either they remove the parathyroid glands with that surgery, or they cut the blood supply to these glands. So that will result in iatrogenic hypoparathyroidism. Either surgical removal, accidental removal of these glands or parathyroid glands during the thyroidectomy, or cut blood supply during the surgical procedure. Idiopathic, which is unknown, the cause is unknown, and most likely it's an autoimmune disease, suspected to be an autoimmune disease. The key studies, I believe that's the last few slides are the key studies, right? So I will definitely go into post the answers for these case studies, because I don't think we have time to go over the answers and the rationales, for each question. Any questions about what we covered today?
Professor, what would
Yes.
be an example of the idiopathic hypoparathyroidism? Right?
Idiopathic?
Yeah.
Remember when we said idiopathic? What do we mean by idiopathic?
So no.
No known cause.
Exactly. It's unknown. We don't know the cause behind it. We don't know what's causing. We don't know exactly what's the causative agent. What's causing that? There is no any identifiable etiology. That's exactly what we mean by the idiopathic. Means unknown etiology. There is no any identifiable etiologic factors. We don't know the cause behind it, but it could be suspected. They said it's suspected that the disease is an autoimmune disease for that idiopathic, when it's idiopathic hypoparathyroidism. If it's not iatrogenic, it could be. If that's idiopathic, that could be like when the theories would explain it as an autoimmune disease. But when you see idiopathic, we didn't know the cause. Cause is unknown. Any other questions? So next week, or on Friday, we will continue with the endocrine system, the other section or the other component and of the endocrine system.